All right, welcome doctors. Welcome to today's program. My name is Dr. Cronk. I'm the CEO of Spinal Kinetics, and I'm very happy to have a guest speaker on our webinar today. We're going to be talking about TBI and cervical spine injuries. One of the things I just want to start by saying is I hope you all are doing well. I understand, the situation that's out there. I think everybody does. And I'm glad you're on. You should be busy. You should be getting back to work. You should definitely be focusing on your injury practices because the injury practices are recession proof. Now, in the injury market today, we at Spinal Kinetics are highly unique because we have a thing called CRMA in which we're doing an excessive motion analysis to determine the severity and location of all ligament damage. Ligament damage is the #1 cause of chronic pain and disability in the market today. All of our studies are reviewed by 2 or 3 licensed professionals. We're unique in that. No one else in the market does that. The key to any injury or the key to any condition, whether it's TBI or it's a cervical injury, is the injury itself. You have to identify what is the problem, right? So excessive motion is the most common problem that causes cervical instability. If you look at cervical instability, you're going to see that it can cause visual disturbances, vagus nerve compressions, drop attack, ear fullness, Meniere's disease, swallowing difficulty, postconcussive syndrome, all of these. So when we're talking about TBI, you look at the common symptoms put out here by Medscape: disturbances in concentration, disturbances in memory, visual disturbances, headaches. Key things. When we look at the cervical cranial syndrome and we look at postconcussive syndrome, these syndromes are very, very similar. And I'm going to tell you right now, as an expert that's been in this market for the longest time, if you are not getting those symptoms to abate, you have missed the ligament injury. You've missed the ligament injury. Ligament injuries today are too easy to determine. You take the patient in, you do a good consult, you start to think with the level based on what they're telling you. And if they're talking about memory disturbances, they're talking about a possible post-concussive syndrome, then you're going to think with the upper cervical, you're going to think in this upper cervical area. Upper cervical numbers lead you immediately. If you have a C5 nerve problem on a motor test, you know that comes out the C4, C5 motion unit. And so your immediate question should be, okay, what is that motion unit like? How much excessive motion is there in that motion unit? If I've got memory, I've got headaches, I've got visual disturbances, I've got things like that, then you need to be thinking about what is the ligament damage up in this area and know exactly how to test for it and how to clinically correlate. That's what the top doctors in the market today do in a matter of minutes. They do this in a matter of minutes. It does not take long. They know that once they have these findings, that they're going to take the stress x-rays, they're going to ship the stress x-rays out, they're going to work with board certified medical radiologists. This is where Spinal Kinetics comes in, and you're going to get an unbiased report that shows exactly how much excessive motion there is. If you have postconcussive syndrome, I'm going to tell you right now, you have these findings. You have these findings unless that trauma was caused by blunt force and there was no movement in the neck. That's the only way I could see a concussive force, a concussion occurring without cervical damage. So with no further ado, who I want to now introduce is Dr. Matthew Twombly. He's a doctor of physical therapy. He has a company called Medical Legal Consultants. And one of the reasons why I wanted to bring him on is he is an expert in consulting attorneys and consulting doctors on how to better document the injuries that a person has, whether it's TBI or the cervical injury. He understands excessive motion testing. He understands what the MRI does and what it doesn't do. He understands what excessive motion testing with stress radiology does and doesn't do. And so we said, hey, would you like to come on with a subject? He said, yeah, I'd like to talk about TBI and spine injury. So we have brought him on. Dr. Twombly, welcome. I'm going to actually change the presenter now for you. You're going to see on your screen, just say yes, it's going to make you the presenter. And perfect.
I think I got it. Can you see my screen there?
Absolutely. We're perfect, and welcome.
Good deal. Thanks so much, Dr. Cronk. I appreciate it. It's a pleasure to be able to speak to this group, and thank you all for making yourselves available. Hope everyone's staying healthy and in good spirits. As Dr. Cronk said, we'll be talking today about the overlap in symptoms and how to differentiate between TBI and its associated symptoms, and cervical spine injuries and their associated symptoms. And I think you're going to find there is a lot more similarity than there is difference. Now, we've only got about 30 minutes today. I'm going to try to keep it to that time frame. It's not a lot of time for this complex topic. So I'm going to be moving relatively quickly on some of the earlier slides. We need to cover those to set the stage for our discussion of how to differentiate and treat these conditions, which I think will be most applicable to clinical practice. And I'm happy to email copies of the presentation afterwards if you want to send me a note. I'll also want to be sharing some insights on the relevance of our discussion to personal injury claim value and provide some both practical and strategic advice to improve not only patient care, but also documentation quality and claim value. Okay. What we're going to cover today, we're going to briefly talk about definition and diagnosis of TBI. We'll talk about the common mechanisms of injury, which Dr. Cronk has already discussed a little bit. We'll cover what a true post-concussion syndrome looks like, the overlap in symptoms between TBI and cervical spine, the specific mechanisms by which cervical spine injury can produce some of these TBI-like symptoms. We'll talk about methods of differentiating TBI and cervical injury. And then we'll talk about some best practice management for both conditions and how this all relates back to personal injury claims. The first question let's cover is why do we need to differentiate in the first place? And most importantly, we never want to miss serious cervical spine injuries because we're biased towards brain injury. You got a diagnosis of brain injury, you're thinking that's the cause, you may miss something significant going on the cervical spine. Similarly, there's a risk of attributing symptoms of a treatable cervical spine injury to a TBI. And the cervical spine is obviously much more adept to a direct treatment than the TBI is. Early activity recommendations are going to differ between these two conditions. Obviously, we want to make sure our treatments are as targeted as possible. And medical accuracy really is the foundation of personal injury claims. We want to make sure, and if you give me a claim, I don't care whether it's a TBI claim or a cervical spine injury claim. As long as it's well documented, I've got good objective evidence of injury, you've correlated that objective evidence with your exam findings, that's what makes a great claim. It doesn't need to be a TBI, so to speak. All right, quickly, the definition of MTBI. The M stands for mild. It's a literature discrepancy between mild, moderate, and severe. 99% of the people you see are going to be mild TBIs. This definition comes from the CDC. And I want to point you to two pieces of this definition. One, Dr. Cronk's already mentioned, you don't need direct trauma to the brain in order to cause a TBI. In the second bullet there, and this is really critical, you do not need positive imaging in order to get a TBI. And in fact, it says right here, your CTs and your MRIs are expected to be negative. And this is really important because we have adjusters calling attorneys all the time saying, well, this isn't a real TBI claim. You've got negative imaging here. It's right here in the ER record. Well, you just refer them back to the definition. That's absolutely not required to have a traumatic brain injury. Diagnostic criteria, and these are going to come, I'm going to specifically present the ACRM, which is a little bit more stringent than the CDC criteria. And there's two parts to the requirements for a diagnosis of TBI. Obviously, we have to have either a blow to the head or evidence of acceleration, deceleration, or whiplash type trauma. Then we've got to have one of these four things: loss of consciousness, amnesia, altered mental state. And this is a big one because probably most of the people that you're going to be diagnosing won't have loss of consciousness or amnesia, but they will have an alteration in mental state, feeling dazed or disoriented. But this is not something people are especially clear on. You're going to have to give them some specific questioning. You may have to say, right after the accident, was there a very brief period where you didn't know where you were, you couldn't get your bearings briefly, and then it came back to you, oh, I was in an accident. That's what being dazed feels like, even though most people haven't ever experienced it. Focal neurologic deficits, the most common are the examples that I've given there. You could also have change in taste or smell, but those are pretty rare. And Dr. Cronk, I don't know if it's on your end, I'm getting a lot of feedback. Could somebody maybe mute their mic?
You still hearing it?
Yeah, I'm still hearing it.
I don't hear it at all.
Okay. Actually, a little bit better now. Okay, TBI diagnosis here. The best tool to use is put out by the CDC. It's called the Acute Concussion Evaluation, or the ACE. This is an excellent tool for you to use on every trauma patient who walks through the door. This is going to walk you through all the symptoms that lead to the diagnosis of concussion or to TBI. It's also going to walk you through a history so that you can find out if people have had prior TBIs. And this is crucial because the effect of TBI is cumulative. If I had a concussion playing football as a kid, I'm more at risk now of having a second TBI with less severe force and in having more significant symptoms associated with that TBI. A quick note on language. Concussion or MTBI. These are exactly the same thing, at least at this point. Until some authority comes out and specifically says they're different, they are exactly the same. And I'm going to tell you, I would recommend you specifically use TBI, at least in a personal injury setting. Adjusters are already trying to draw distinctions between concussion and TBI. I had an adjuster recently call one of the attorneys I work with and say, yeah, you don't really have a serious claim here because they only got diagnosed with concussion, not with TBI. Now, that's a ridiculous assertion, but it's another excuse for insurance companies to delay and deny and lowball claims. So don't give them that ammunition. Here are the codes to use. This focal traumatic brain injury code is more appropriate for your direct blunt trauma, and the other two really work for anything. TBI diagnosis stands on its own. What I see very often in neurologist notes is possible TBI. There is no possible TBI. Either someone meets the diagnostic criteria or they don't. Now, what we're discussing today is, do they have a post-concussion syndrome, and are those symptoms due to TBI or potentially to the cervical spine or PTSD or vestibular system, any number of things. But the diagnosis of TBI should specifically be made based on those criteria we talked about. Okay, the mechanisms of injury, and here's the secret. TBI and cervical spine have identical mechanisms of injury. You got blunt trauma, and as Dr. Cronk said, there's really no instance where you're going to have blunt trauma to the head that can cause a TBI and not also impart enough force into the cervical spine to cause injury there. And on the other side of the spectrum, a whiplash or acceleration-deceleration type of injury is obviously going to cause injury to the neck, but it can also cause injury to the brain. And I'll show you a picture here in just a second of how that works. First, our focal traumatic brain injury, where either something strikes the head or the head strikes something and the brain is concussed at the point of impact. That's our coup injury. Contra coup is where the brain then rebounds and strikes the opposite side of the skull. You have a multifocal brain injury here. Now, on our whiplash or acceleration-deceleration mediated brain injuries, in this picture, it shows the head actually striking the headrest, but that's not necessary to have the forces involved to cause a brain injury. when you have acceleration deceleration or whiplash, and they're kind of synonymous in terms of the mechanism of injury, you have shearing forces that affect the brain. And in this lower left picture here, you can see there's two different types of tissue, of course, in the brain. We've got white matter and gray matter, but they're different densities. They accelerate at different rates. So when the whole brain is accelerated, there's going to be shearing at the junction between these tissues. In addition, the axons of the neurons in the brain can be sheared with those shearing forces. But even more important, it's the inflammatory cascade that is caused by TBI that's both underreported and causes the most damage. That inflammatory cascade causes inflammation of the brain, other areas of the body, and that brain inflammation can cause what's called Wallerian degeneration, which is prolonged degeneration until ultimately it renders these axons non-functional. And this degeneration and inflammation can go on for decades after a TBI. We'll talk about some mechanisms to try to stop that inflammatory cascade. Okay, so as I mentioned, post-concussion syndrome is really the differential that we're looking at here today. Now, the diagnosis of TBI is completely independent from cervical spine. The diagnosis of post-concussion syndrome may very well be dependent on whether symptoms are more likely due to cervical injuries. This is the ICD-10 criteria to diagnose post-concussion syndrome. Obviously, we need the history of TBI, and then we're going to have the presence of 3 of these 8. The first 7 are pretty standard. The 8th is relatively new. You don't hear about that very often in post-concussion syndrome, and we won't be able to talk about it today because there's really no literature out there to try to determine whether intolerance to alcohol can differentiate between a brain injury-induced symptom and a cervical spine-induced symptom. So it's something to keep an eye on. The best way to identify these symptoms in general is to use a tool like the Rivermead Post-Concussion Symptoms Questionnaire. This is what that looks like. This is a great tool to use with your patients in order to identify a host of post-concussive symptoms. Doesn't matter what the origin of those symptoms is this is perfectly valid if it's brain injury or if it's cervical spine. And because you have a Likert scale here, it's going to be sensitive to change during treatment. So you can monitor whether people are improving. All right, let's talk about the difference in symptoms and if there are any symptoms that truly differentiate between a brain injury-induced post-concussive syndrome and a cervical spine-induced post-concussive type syndrome. On the left, this table comes from a study that's called Brain or Sprain, and they were specifically trying to address the question that we're asking today. Is there a way to clearly differentiate between TBI and cervical spine-induced symptoms? And if so, which of those symptoms tends to differentiate between the two most effectively? So the symptoms are over on the left. And as you look down that list, for me, traditionally at least, the symptoms of feeling slowed down and feeling mentally foggy, difficulty concentrating, difficulty remembering, those are typically what we attribute to brain injury. Now, over on the right side, there's a little bit of an error here in the study where they produced this table and noted that there were some significant differences with some of these. Then they went on to discuss some additional number crunching and statistical analysis they did, which eventually showed there was, in fact, no significant difference. In other words, every one of these symptoms was indeterminate in being able to distinguish between TBI and cervical spine related symptoms. So the conclusion here, can we differentiate between these two entities by symptoms? Absolutely not. And I want to point you to one point here, the second half of this statement. Clinicians should consider specific testing of exercise tolerance and perform a physical exam of the cervical and vestibular ocular systems to determine etiology of post-concussion symptoms. There is some promise in exercise tolerance testing for differentiating between these two entities. And we'll talk about that a little bit later. So by what mechanisms, and Dr. Cronk already stole my thunder here a little bit, but how does the cervical spine actually produce post-concussion syndrome? And number one, it's with cervical instability, right? Trauma-induced ligament laxity can result in all of these conditions, many of which are quite serious. For those who may not be familiar with Barlow syndrome, it's a disruption of the sympathetic pathways through the cervical spine. Again, it's caused by typically translational instability, often in the middle cervical spine. And these others are frequently caused by atlantoaxial instability. So this is a critical piece of being able to differentiate between cervical spine mediated symptoms and brain injury mediated symptoms. The other thing to pay attention here is all tissues in the cervical spine are providing feedback to the brain. So the joint tissues, the muscles, ligaments, tendons, discs, they're all providing information on force and position and speed of movement and tensile force into areas of the brain that are simultaneously receiving information from the ocular system and the vestibular system. Now, if there is a mismatch in information, if there's erroneous information coming from injured cervical tissues, you get a sensory mismatch in the brain, which can lead to symptoms like dizziness, disorientation, balance disturbances that are specifically the result of the cervical spine injury. Now, the last two I want to talk about are really important because we all know that cervical spine injuries are going to cause pain. They're going to frequently cause headaches. They're going to cause sleep disturbance. And the fact is that pain by itself, in the absence of TBI, in the absence of psychological diagnoses, even if someone's not taking opioids, pain causes cognitive impairments, causes attention and concentration deficits, processing speed and psychomotor speed changes. Similarly, sleep disturbance. If people are getting significantly less than 6 hours a night on a regular basis, or even a single night where they just get a couple hours, we are going to see cognitive changes. We're going to have decreased vigilance, attention, decreased memory processing. So these two areas alone that are so frequently associated with cervical injuries can cause effectively all of the symptoms that we typically associate with post-concussive syndrome. And we'll talk about how to differentiate these a little bit clinically. Now, this is a list of symptoms that many of those disorders we just mentioned that are primarily associated with cervical instability can cause. And you see post-concussion syndrome here sort of compared with these other conditions. All of the rest are related to cervical injuries. And you see there's nothing unique about the symptoms of post-concussion syndrome. They can be caused by multiple other cervical types of injuries. I do want to draw your attention to speech disturbances because post-concussion syndrome absolutely can cause speech disturbance. And in fact, word-finding difficulties, also called anomic aphasia, is very common after TBI. And I'd encourage all of you to include in your TBI intake a question about whether your patient is having difficulty finding the right word, retrieving the right word, expressing the thoughts that are in their head. Like they know the word, it's not something outside of their knowledge base, they just can't produce it when they want to. And that may be a symptom that can help differentiate brain injury from cervical spine. But that's just my thoughts. It hasn't been studied yet. One important note here, anytime you have people complaining of dysphagia or difficulty swallowing, that's not going to be caused by a brain injury. You need to look for serious cervical spine injuries. So how are we going to clinically differentiate these? First, as Dr. Cronk's already mentioned, we've got to identify cervical instability. And we start doing that by looking for ligament laxity. And the best way to do that remains with flexion extension x-rays. And you've got to include AP open mouth views and lateral flexion. I don't know why so many chiropractors I work with aren't including those views, because there's no better way to identify atlantoaxial ligament injury, to transverse ligaments, alars, than by doing these AP open mouth views in side bending. So please do these studies, get them mensurated so that we can get objective evidence of this instability. And you've got to also take the next step of correlating these findings with your physical and subjective exam. Just like Dr. Cronk had mentioned, if you're looking at the C5 nerve, you've got to be able to correlate that back to where the instability is in the neck and link that to your flexion extension x-ray findings. There's some great tests out there to identify cervicogenic sources of dizziness, vertigo, and balance deficits by ruling out the vestibular and ocular and other brain systems. This is what those are. We're not going to go through those specifically, but for those of you who would like to incorporate those into your clinical practice, and I highly recommend it. There's a great study in the Journal of Athletic Training from 2016 by Kelly Cheever, Cheever. And it details these tests as well as a pretty solid sensitivity and specificity for these tests. Okay, some additional methods. We talked about exertion testing, and this might hold the most promise, although it's difficult to implement clinically. So the Buffalo Concussion Treadmill Test was specifically designed for this purpose, to take advantage of the fact that we know autonomic dysfunction accompanies brain injury. And that autonomic dysfunction causes, as levels of exertion increase, you expect to see early onset of worsening post-concussive symptoms. So as someone speeds up on a treadmill, for example, if they had a brain injury, you would expect to see early worsening of headache or dizziness or nausea. And this is a critical point clinically because we need to know whether someone is at risk, especially early after a TBI, of possibly fainting when they go out for a walk. And we'll talk more about this clinically, but we definitely want to be asking people about how they respond when their exertion increases, because this is a strong indicator of symptoms coming from a true TBI. We definitely want to ask specific questions about pain and sleep. And here's what I'd like for people to be asking related to pain. Do you notice if your cognitive problems, your dizziness, light noise sensitivity, balance deficits, are they occurring solely in the presence of moderate to severe cervical or headache pain? Because if they are, there's a pretty decent chance that our cervical spine-induced injuries are what are causing these post-concussive symptoms, like our memory problems, for example. If they're not, so if the concentration problems, the memory difficulties, if those are occurring independent of pain and headaches, then there's a good chance that that is a TBI-mediated symptom. Similarly with sleep, we want to know how much are they getting. As I mentioned, if they're in the 3 to 5 hour a night range, that's simply not enough. They're absolutely going to be experiencing, not only severe fatigue and, risk of falling asleep at the wheel, but also cognitive deficits. We also want to know what's preventing them from sleeping. Are they having anxiety, which is very common after car accidents? Get them to a counselor. Are they having pain? There's certainly things that we can treat, and we'll talk about those. And don't be afraid to get a neuropsychologist involved when you have ongoing cognitive symptoms. Even if you don't know what the source is, it doesn't matter. Could be because of pain, could be because of instability. Regardless, we want those documented for the purposes of identifying value drivers in the claim, because cognitive deficits are profoundly impairing for people's lives. They can cause disability at work, and they can change people's relationships, the way they can take care of their kids. These are really important symptoms to get documented And neuropsychologists can do the objective testing to make sure those things get documented. And then you can let them figure out the specific source. They think it's due to TBI, great. They think it's due to sleep or pain, fine. It's still all linked to the trauma and still important to get documented. All right, let's talk about some clinical implications in general, then we'll talk about how to clinically differentiate. Always assess for TBI. Always monitor neurological symptoms. Use the ACE and the River-Mead forms on every trauma patient. Anytime TBI diagnostic criteria are met, start treating the TBI and do it early. Also consider referring, especially in the first couple of weeks, certainly in the first month or two, for an EEG with evoked potentials or event-related potentials. There are a number of different ways to get these portable EEGs now, and they can be extremely successful in identifying physiological change in the brain that we can link with concussion. Anytime you have the presence of post-concussive symptoms, look for cervical instability. If symptoms are persisting beyond 2 weeks, unless the person already went to a psychiatrist and they're medicated for PTSD and we know that's causing cognitive problems, in the absence of something like that, make sure you get them to a medical doctor to confirm the diagnosis of TBI. Insurers will require that a medical doctor has confirmed that diagnosis in order to consider it in claim valuation. Always assume both TBI and cervical injury are present until there is conclusive proof otherwise. And if cognitive symptoms are persisting beyond 3 months, that's when you want to try to involve a neuropsychologist. Okay, some recommendations here quickly on treatment. Some really important early TBI interventions. I talked about the inflammatory cascade that is so crucial after a TBI in damaging both the brain and other areas of the body. Everybody should be on antioxidants and anti-inflammatory supplements. Fish oil has already been shown to be extremely successful in helping the brain repair and diminishing the effects of that inflammatory process. There are multiple antioxidants that people can be on, and everybody should be on probiotics as well, because this inflammatory cascade affects not only the brain, but certainly the microbiome as well, which is critical for overall health. If you want a list of some of those supplements, send me an email, I can send those to you. A gradual cardio program is really important. Even with a true TBI, where we're concerned about somebody, potentially fainting if they try to work too hard or, try to increase their exercise too quickly, I would encourage you very strongly to institute a very gradual cardio program with close monitoring in your clinic, because it does improve the rapidity of brain recovery and help diminish that inflammatory cascade as well. There are lots of sources now, phone apps, online free resources that offer brain games. And there's great literature to show that brain games do, in fact, improve recovery from cognitive symptoms after brain injury. Again, I can send you some of those links if you want. Cervical instability interventions. I'm speaking to a group of experts on the cervical spine, so I'm going to keep these fairly generic. But one thing I've noticed is that a lot of chiropractors that I work with have told me, yeah, I don't touch the cervical spine for the first month or more after a trauma. And the problem with that is we're leaving a lot of treatment options off the table. And if we're not willing to go in and, yeah, sure, be judicious with your high velocity thrusting, but there are lots of ways to mobilize joints and soft tissues that can make a huge difference, especially if you have, for example, a C1-2 malpositioning that isn't going to respond to any other treatment. Trigger point injections can be great, but keep in mind that if you're needing to do repeated trigger point injections, it's almost a certainty that there's underlying instability, and those muscles continue to guard and spasm because they're trying to protect from that excessive motion. So look deeper if you're having to repeat those. And there's been some pretty good promise in the literature for prolotherapy. So if people are not responding to conservative care, then this is always something to be able to consider for a long-term intervention for cervical instability. Sleep interventions. It's so important to give these as much attention as we do every other part of treatment. Because if people are not sleeping after trauma, they're not recovering. Their body is not healing. And this is absolutely crucial. And it's simple, number one, just to talk to them about good hygiene, positioning pillows, temperature, noise, light, make sure it's dark in the room, kick the dog off the bed. These are simple things, but can make a big difference when pain is interfering with sleep, or even TBI-induced sleep dysfunction is causing people to wake up frequently. Make the referral to counseling. If somebody says that anxiety is disrupting sleep, that can be extremely effective. Don't hesitate to refer to a medical doc for sleep meds if they are not responding to other treatments and are not sleeping. Again, you can't heal if you're not sleeping. I am not in love with medications for sleep, but there is a time when those can be extremely important to help someone recover. Okay, let's talk about some of the implications of our discussion here today for personal injury claims. Number one is, again, I don't care what the source of symptoms is. I'm not wedded to TBI, even though that's an area of expertise for me. I'm happy to work up TBI claims, but working up a cervical spine claim that's causing memory problems, it's causing some disability at work, that can be just as valuable. And there's a lot that needs to be done with that, but I've got to have a solid medical foundation. And as Dr. Cronk does in his daily work, he helps clinicians identify the cervical instability, correlate it, document it appropriately, relate it back to the imaging, get the right diagnosis, show how that's impacting people functionally, and the fact that there isn't any clear treatment that long-term is going to just remove this entirely. So this is a really important point here, that I need the accurate medical basis in order to build the claim. And that comes from you as that frontline practitioner who has the expertise to put these pieces together. Because there aren't many other clinicians out there who have the expertise to marry these flexion extension findings of ligament laxity with instability and facet arthrosis and how that affects the disc. That needs to come from you. Early documentation of TBI is crucial. I can't tell you how many cases I get from attorneys at 6 to 24 months where they say, yeah, I'm concerned there might be a TBI, but I don't know. We screened the patients, clear they had a TBI, but we look at the records and there's not a shred of evidence that a TBI was sustained. There's no indication that they hit their head on the airbag. There's no documentation of early headache. There's no documentation they were disoriented right afterwards. You can be that gap, or you can fill that gap where we can then go back and look and say, okay, look, there's great documentation here early on that they had all of these different symptoms are listed right here on this acute concussion evaluation form. We can very easily now go in and develop all the arguments we need to build a really solid case. If you talk to an insurance expert like James Mathis, who has mentored me in how insurance companies value claims and treat value drivers and how their software systems work in terms of assessing medical records and assigning settlement values, they'll tell you that treatment is a huge value driver. And that may seem a little strange, but in TBI, it's actually very rare that people get treatment. And I've given you a few options to start treatment, such as supplements and graded activity programs. documenting those is really crucial because software systems actually place a high value when people perform home treatments because it shows they're committed. And if you document not only that you've given this to them, but document on an ongoing basis that they're complying, that adds a lot of value to the claim. Now, please don't use the information I've given you today to make opinions like this. Well, I've looked at all the evidence, and it's my opinion that these memory and cognitive symptoms are due to the cervical spine injury and not to a brain injury. Don't put yourself in that position. I don't want to receive hate mail. You don't want to make attorneys angry. That kind of statement should be better left to a different professional like a neuropsychologist or neurologist. When you make referrals to medical doctors associated with TBI, sleep problems, etc., make sure that you give that physician as much information as you possibly can so that you point them in the right direction. Keep in mind that most of the medical docs out there, they don't have a lot of training or understanding of TBI. So if you send them a patient and say, hey, confirm TBI, they don't know how to do that. So you need to give them information to work with. Tell them, hey, this person, hit their head on the window, or I believe, they had an acceleration-deceleration injury of the brain. Here were the symptoms they had after the accident. Here are their ongoing symptoms. Please evaluate for TBI. Right? Then they know what to do. Then they've got the diagnostic criteria right there in front of them. Don't depend on them to generate it themselves. Okay, I appreciate your attention today. Here's some resources that I think may be helpful for you as you further investigate some of these items. Dr. Cronk has a great program called Smart Injury Doctors, and that's, I've already discussed it a little bit, where you're going to get a lot more information on how to work up, identify, and treat cervical instability. If you want information on how insurers value claims, I strongly recommend you attend a seminar with Jim Mathis. And if you have questions for us, there's my email. You can go to our website. You can email us through the website as well. And we're happy to respond in that manner as well. Thanks again, Dr. Cronk.
Okay, perfect. Very, very, very good presentation. I'm going to change presenters. So doctors, look at those resources that he just put up. Go out to the traumaexperts.com, take Dr. Matthew at protonmail.com. If you have questions, you have anything that you want to talk to him about regarding today's program, I thought it was one of the better programs that I've seen on very much simplifying what you should do in order to assist assist in the documentation of the fact that the patient may have a mild traumatic brain injury. Very, very good presentation. I'm going to show my screen. I'm going to finish and conclude always, and I'll take questions. We'll take any questions in just a second. One of the things that got stressed again today, and I really appreciate Dr. Twombly, you're stressing it, is obviously cervical instability. I've been talking about it for years, is the primary thing that you need to be looking for as doctors of chiropractic, whether you're doctor of chiropractic, doctor of physical therapy, doctor of osteopathy, doctor of medicine. If you're going to treat injured patients and injured spinal patients, ligament trauma causes two findings. One, disc herniation, but there's only 23 discs. There's 220 specialized ligaments. The other imaging finding is excessive motion. And so that's why we at Spinal Kinetics exist. We exist to make doctors better doctors. We exist to enhance the doctor with understanding that patient's injury so that you can get those patients better. We exist to enhance the professionalism of the doctors that are treating these injuries. All right, and if you need to reach us, if you're new to Spinal Kinetics, you don't have an account set up with us, 877-508-9729, or you can visit us at thespinalkinetics.com. Okay, questions? Very good presentation. What if you provide clear-cut findings of TBI and they rule out TBI which can hurt the case. Okay, so that's a which in other words, the you send it to the MD, and the MD says no, they don't have a TBI. Well, first of all, I'm gonna help with that one. It doesn't hurt the case. If you basically said, I think the person's got an amputated arm because you didn't know how to determine if they had an amputated arm or not, and you sent it out to a doctor and they said, no, they don't have an amputated arm, it doesn't hurt the case because the case never included an amputated arm in the first place. Would you agree, Dr. Twombly?
Sure. And I mean, that does happen. And, you know, part of the reason why it's so important to point doctors in the right direction is to make sure they have all the evidence to make a good determination. And, you know, sometimes they get it wrong, and sometimes they may be right, and there's a different etiology for those symptoms. And hopefully, if you've already worked up the cervical system, the vestibular system, maybe there needs to be a referral for neuropsych to look at potential PTSD, then you've covered all your bases. And, you know, one thing I didn't mention is there are plenty of cases where people have very legitimate symptoms and there is a physiological source, but instead of finding it, some practitioners will just label them as, well, I'm not sure if they're being honest. They got some secondary gain issues. In fact, there's studies out there that have looked at this particular question and just said, it's not even worth looking into because people in litigation scenarios are all lying. That's ridiculous. That's just an opinion by folks who aren't doing a good clinical job of differentiating.
All right, here's a question. We have an attorney online. He's asking, in your experience, how easy is it to find doctors, whether medical doctors or chiropractors, that know how to do a standard spinal instability evaluation? You can go ahead and tell them the truth.
I'm going to let you take that one.
Yeah, I'm going to tell you the truth. The typical doctor out there not only does not do it, but does not know how to do it. And that's a problem in the market. That's a problem with everything that Dr. Twombly just talked about. So it's not hard. You can call groups like Spinal Kinetics, and we can direct you to doctors that routinely use our services, but that's not an easy thing. TBI and spinal instability is probably the most underdocumented, underdiagnosed condition in the market today, and yet it's the #1 cause of chronic pain and disability in the market today. So there are too few doctors, I've said this for years, there are too few doctors that understand how to do this, and the ones that do are gold, absolute gold. You saw what I showed very quickly on how a workup should be. Dr. Twombly's presentation and many other experts like Dr. Twombly will say, you need to have this type of workup, right? You need to have this type of workup. I know that he oftentimes, Matt, when you go into work for a new attorney firm, and the attorney firm is saying, hey, what's wrong with my claim, or how can I do a better job of representing the person's condition? Wouldn't it be true that the #1 problem that you have is really poor documentation from the doctors? They haven't established what the injury really is, let alone the severity and location of that injury. And then it kind of cascades downhill from there. Would you say that's true?
Yeah, no question. And one of the first things I do on many claims is I go in and I have to go back to a treating chiropractor and ask them to get a full set of flexion extension x-rays, because that almost inevitably has not been addressed at all. And that's part of the reason why I've been promoting spinal kinetics for years. You know, Dr. Cronk, I didn't meet you until just a few months ago, but the service is so valuable. It's just crucial to provide objective evidence of an otherwise difficult to see type of problem, and that's spinal instability.
Yeah, absolutely. So what I would say to this attorney who's asking the question is, you would call Spinal Kinetics and find out in your local area who the providers are. You call Dr. Twombly, and I definitely would highly recommend that you contact him and ask him, because my experience also is that the majority of attorneys are highly deficient in their understanding of the injuries that they represent. And it's no cut on the attorneys. It's no cut at all on attorneys, because nobody's come out and said, hey, this is what you need to understand in order to understand the injury itself. How severely damaged is your client? And how do you back that up? How have your doctors backed it up? So let me see if I've got any others. Audio. Here's what I want to tell you, doctors, on audio cut in and out. With the stay-at-home orders in most of the states, services like GoToMeeting or Zoom or all of these services are overwhelmed with people on the systems. And so the systems aren't performing quite as well as they normally do, and that could be the cause of the problem. Okay, here's a question. In your experience, what have you seen as the best rehab for TBI? Hyperbaric, cognitive function, brain rehab, Care Institute, Amen Clinic. I'm not familiar with one of those. Amen Clinic, I'm not familiar with it. That's a question.
Yeah, the best answer is early intervention in every case. And, the simple things that I mentioned are some of the most critical. Get people moving, make sure they're on a regular cardiovascular exercise program, ensure they're taking the supplements to diminish that inflammatory cascade, and then absolutely address both the psychological and cognitive aspects of the brain injury, while of course paying attention to sleep. There's no clear winner in terms of a new technology, or like you mentioned, hyperbaric. There is some evidence. In fact, I've worked with the best expert in the country. His name is Glenn Weaver in Utah, who is a hyperbaric expert and does a ton of studies on TBI. And there is some promise there, but the practicality of getting people to a hyperbaric chamber, immediately after TBI, it's never going to be widespread.
Absolutely. Plus, doctors, Dr. Twombly made a really good, when he's looking at, okay, good, his supplements are easy. Sleep, making sure the person gets enough sleep. Sleep is when they heal. Making sure they get enough sleep. Making sure they have the right nutrition. Making sure they're hydrated. The majority of the public is dehydrated as all get out. And dehydration will add to an inflammatory effect in the body. What he said, getting on the, which I had not heard before, and it was a great thing. It's something I learned today on this program, was getting involved with a, cardiovascular program of some kind, a cardio program of some kind, to assist with that, to get them moving. It's fantastic. And, always, the thing is, you always want to start simple. Those are simple things that you can be doing week one. I mean, what spinal ligament injury should not have good hydration, good sleep, good nutrition in order to assist it with healing? All of them should. This is the doctor that says, should I send out for x-rays and then send them to you? Yes. Doctor, I'm going to make a statement that may be an interesting statement from your point of view. It is impossible to determine spinal instability without the testing. You can't determine. So you can have a what's the percussor? What's the orthopedic test, Dr. Twombly, for instability? It's more in the
like a sharp purser, for example.
Like a sharp purser. You could have an orthopedic test, but I'm telling you that test does not hold up as to, you could not definitively say, look, there's excessive motion in the spine. From an orthopedic test, there is no examination procedure. There's only clinical correlation of the examination procedures with the x-ray findings themselves. So the only way you can determine the severity and location of any ligament injury is through testing, and it's through imaging. So if you want to know how badly damaged your patient is, I did on every single patient in my practice from 1995 to the time I finished. There was not an injured patient that did not get a excessive motion test done in my, it wasn't done in my clinic. I sent out for the testing, and always why I sent out for the testing. This is back in the days when I used to draw my own x-rays on a view box. I always sent out for the testing because I wanted the testing. I knew the results were so significant that I wanted them done unbiased. You, the treating provider, are looked upon as biased. Plus, you're looked upon as you will manipulate the study. You will manipulate the intensity, the severity, the location. You will manipulate that because you have a vested interest in doing it because you're getting paid for treatment. So it knocks out all of those things that come up in depots and come up in, and also it knocks out the perception that it's not very professional. It knocks out that whole that whole perception. So yeah, you definitely should. Yes. All right. Okay, I don't see any other questions. Again, if you have further questions for Dr. Twombly, he gave his contact material, his contact information. Contact him. He, like me or any other, content expert, is happy to discuss and to help you in situations where you feel like you need help. So, Dr. Twombly, I really appreciate you taking the time today. I know even though we're in the COVID virus lockdown, that you've been very, very busy. So I really appreciate your time. You gave great content today, very simple, very easy to understand, and actually clinically workable to put in these forms tomorrow. So very, very, thank you very much for that information.
Absolutely. Thanks for giving me the opportunity to speak. I appreciate it.
Okay, doctors, we will see you probably next week. We're trying to do as many informative programs as we can to help you out. I thank you very much for your time and attention today. Have a good rest of the week.